I'm gonna have a chat with you about one of the interesting cases I've recently seen just before Christmas during my own calls in Huddersfield. Those of you will know that Calderdale and Huddersfield work together. And basically the structure of my presentation is really, we're going to start off, it's going to be case-based. And we are going to start off by reviewing the case details, hopefully move on to agree based on the case details, agree on the diagnosis and the management plan, and review really lastly the salient issues affecting the management for the case. To the next one, right? So for the case, so 70-year-old female who attended A&E straight to resus with 2 days of confusion following the death of her brother. The family was concerned that after the death of her brother, she stopped, talking, she stopped engaging, she was unable to walk, she didn't have any fever, she was just not well herself, grieving badly. Reviewing her in terms of past medical history, it was noted that she had a history of hypertension, type 2 diabetes. She was known to have schizophrenia, for which she was being managed for by the psychiatric team. She'd also been treated for breast cancer 10 years before, and she'd been deemed clear. In terms of medications, those are the medications that she was on. Her physical examination, because of the confusion, the GCS was scored at 14 due to the confusion. Her blood pressure was stable, heart rate was stable, she had no fever, the resps were okay, she was maintaining SATs on room air. She had moist mucous membranes, the capillary fill was okay, she had no evidence of peripheral edema, no rash. Listening to her chest, it was clear. Abdomen was soft, non-tender. So at that point, I'm just gonna go to the chart briefly to see at the moment so far with everything that we have, what people think, what's going through people's mind. So that is we've seen the case, we've seen the physical examination. I'm sure, well, all of you are doing on calls. I just wanted to find out what people would be thinking of doing at this point in time. So I'm just gonna go to the chat box, quickly have a look. So 3 new messages. At this moment, what investigations, what things are running through your mind? So medication overdose, self-neglect, so do a urine dip, collateral history, what brother carer? So it was the older brother who passed away, was not her carer. Any tests people want to do at this moment with the history? So we've got collateral history, very good, very important. Any tests people are thinking of and why? Urine, a PR, is that for constipation? She'd been opening her bowels well. Medication review, we've seen the medications, yes. Chest x-ray, yes, very good. Any further tests? Yes, UNEs, TFTs, B12, folate, okay. VBG, very good. Full exam, evidence of trauma, good, good, good. Yeah, so let's see what we did in our case. So we did a couple of things, and so I don't know, nobody mentioned the city head, but anyway, we did it. I don't know if it was felt that it was unjustified, but we did it to make sure there was no. So the reason we did a city head, although we've not suggested, she had a history of breast cancer that had been treated before. So we did a city head, make sure she does not have any intracranial pathology like metastatic recurrence of the disease. It could have hemorrhaged and it's causing the confusion. So the CT was okay. We did an ECG. I'm not sure I've seen that, if I've forgotten. So we did the ECG. It had normal, the ECG was normal sinus rhythm with normal QTC, Neil Osborne waves. So confusion, ECG, what are we thinking about? So we are thinking about other things that can cause like electrolyte abnormalities that can cause confusion. Electrolytes like calcium, hypercalcemia can cause you confusion and can cause a shortened QTC. Commonly, we see a prolonged QTC, but you can have a short QTC as well. So you can get an idea, can give you Osborne waves. That's why we did it. Chest X-ray, it was mentioned by somebody. I'm not very sure what the rationale was here. When somebody said, let's see, who was it? I'm just going to go back to the chat box briefly. Why would we do a chest X-ray in a confused patient? Somebody has mentioned a chest X-ray. What are we thinking about for the chest X-ray? Are we thinking about a pneumothorax? There are many reasons why we could do chest infection. Yes, I agree. Maybe missed on auscultation. Yes, I agree. CAP, yes, can cause a delirium completely. Yes, septic screen. But other causes for chest X-ray, you could also have a malignancy that can cause some malignancies can cause confusion through. Yes, that is Ali has gone through it as finding the way to put it. So what is it called? Paraneoplastic. Yes, small cell lung cancer. Yes, paraneoplastic mechanisms. So a chest X-ray is also a good thing. Yes, I agree. Yeah, thank you, Daniela. So small cell lung cancer is the commonest in that case. So we did a chest X-ray for that reason. Well, it was rotated, but we didn't see much. So chest X-ray. Then just trying to go to the next thing. What did we do? I think somebody mentioned a gas. Yes, we did a gas, and reasons we know if you have a metabolic derangement, mainly acidosis, people can be confused. So wasn't, you know, our lactate was okay, the glucose was okay, and the pH was okay. And then we did the rest of the blood. Somebody also mentioned UNEs and the rest of the things. I've not put the CRP here, but the CRP was okay. HB was okay. And has anybody noted anything conspicuous on those bloods? Just gonna go back to the chat box. If anybody has noted anything conspicuous likely to be explaining the confusion. So if you see the bloods, yeah, hyponatremia, very good. So everybody has, so we got the bloods, we wondered, you know, she had really significant severe hyponatremia. Very well. So we wondered whether this, we felt, you know, based on things we felt, it's probably this hyponatremia that was causing the problem. So the next thing you want to do when you have a patient with hyponatremia, you want to check the volume status. We've checked from the examination. She looks physically as though she's euvolemic. So we calculated the plasma osmolarity. There's equations that can be used, and the plasma osmolarity came back at 213. The normal range is meant to be about 275 to just under 300 millosmoles per kilogram. And because of that, so we had it showed us, it suggested to us that, you know, she had very dilute blood. And, you know, we went back to review the history. Reviewing the history, this lady, it was mentioned by the relatives that she had a habit of drinking too much water every time she was trying to drink water. And even in A&E, she had a big bottle, 1.5 liters of water that they were giving her at that moment. So with polydipsia. Polydipsia, although different resources might quote different thresholds, taking way too much fluid, as we can see. Now, I wanted to mention here, usually when we're dealing with the hyponatremia, the common way we look at it is if they are low volume, euvolemic, or high volume, hypervolemic natremia. So the physical assessment sometimes, it's very good. Sometimes it's very clear. You see they are dehydrated, like patients who come in with pneumonia, AKI, or abdominalitis. Very easy to see that, no, they are quite hypovolemic, low volume. But sometimes others come in with heart failure, renal failure, whichever organ failure, and it's clear that the volume of fluid is quite high. But then sometimes they can be slight overlaps. And in this patient, there was no clear indication that she was hypervolemic. So actually, the first review from ITU was to give her, when I went to see her, she'd been started on a bag of, if it's euvolemia, the guidance is to try and give them normal saline. So she's been started on normal saline. But when we took the history, calculated those modalities, I felt that, no, probably we shouldn't be giving her any IV fluids. We should be doing the reverse, given the history. Somebody has been putting collateral history. So we've used the collateral history, we've used the clinical examination, we've used the investigations, and worked out, and we think, no, it's more likely to be too much water that she's taking and is causing a dilutional component. So we treated this as likely a hyponatremia due to psychogenic polydipsia. It's important to check other things before other things can affect. Okay, my thing is not moving. Okay, so it's important to do additional tests that, to make sure there are no other mimics. So we checked the calcium. Calcium was normal. Remember, we talked about it earlier. Hypercalcemia can cause you to have polyuria, can cause confusion. And because you're weighing a lot, you're dehydrated, you can be also drinking a lot. So polyuria. We checked the TFTs, make sure that they are normal. We checked high urine osmolality, paired osmolarities. We did the blood, we did the urine, and we can see that it is slightly on the lower side. And the working diagnosis, as per that time, I changed to psychogenic polydipsia, stopped the IV fluids, and put in a plan for the reverse fluid restriction. And we then reviewed the medications. So the medications she was on, as we talked, some of the medications could drop the sodium. So we suspended them. I think paroxetine was the one that was on there. We stopped them. Other medications, if you have like RAS, it might not be the exact cause, but if the sodium is that low, you probably don't want to be dropping any more sodium. And with that plan, so I saw her on the 17th, using that plan, we can see that her sodium started increasing from 101. The following day, it was 110, evening, in the morning 110, evening, afternoon 114, climbed up to the 22nd of December, just, going into Christmas. The sodium had gone to 126. She was discharged because she was better in herself. The plan was working. And then review of through the virtual, we have virtual reviews in this trust. Her sodium had climbed up just before, on the eve of Christmas, back to 132. So I've used the first half to go through that. Just gonna go through salient issues of this case. Psychogenic polydipsia, patients drinking too much water. It is known that, statistics are always variable depending on the population cohort you're looking at, but you would say around 18% give plus minus of patients with schizophrenia have attended acute, have attended hospitals with psychogenic polydipsia. It is also known to be seen in people with depression, autism, bipolar. The pathophysiology, why this happens, remains unclear. There are several hypotheses, some relating to anticholinergic medications through causing a lot of thirst, dry mouth thirst, and people are drinking a lot. There are people who are healthy, younger, lifestyle, not even having, even normal people get psychogenic polydipsia, but they just think it's a good lifestyle of drinking, and they just drink, increasing their dopaminergic reward. There is been a small study done in about 2017 between schizophrenics that were getting psychogenic polydipsia versus those ones who are not, and it looked like the ones who were getting it were having a small hippocampus, There are a couple of hypotheses, some that I've not listed, but there is no clear consensus on why it happens. In terms of physical manifestations, people are drinking lots of water and they are not excreting this water very well. They dilute the sodium. So the symptoms are likely going to be mainly due to hyponatremia. So if we can use, again, the chat box to see. So if you have hyponatremia, Danielle Brown, is that a 13 mol increase in 24 hours? Don't know. We shall come back to it, Danielle. I need to calculate. The answer is I don't know. I need to calculate, but I think it is not. We'll have a look at it. So if we just so hyponatremia. So these patients are going to present with symptoms consistent with the hyponatremia. Do we know of any symptoms people are going to present with? Signs, symptoms, likely patients who are drinking too much water, diluting, getting a hypervolemic hyponatremia. If you use the chat box, we'll take a minute to have a look at what symptoms from your experience you'd expect. Falls, seizures, yes. Headache, coma, yes. Seizures, irritability, confusion, yes. Look, very good, very good. So looks like we have a very good understanding of how people are likely to present. So they will present with vague symptoms, but there are more serious symptoms like seizures, coma. The one that has not been put in the chat box is death. So common symptoms, I put symptoms from nausea, vomiting, confusion, a bit of ataxia, non-specific. But, as we go down, there are more serious ones, especially people can, when they're having seizures, they can as well die. I've also put in a screenshot of that, of the case that you might know in last year. So that is on Sky. I hope it shows the date. So that is on Thursday, 21st September. I hope it's clear on 2023, when the coroner ruled that it was our responsibility. Note this, it was actually in Scotland, an 18-year-old patient who died because of drinking too much water. So I just wanted to mention that, yes, there's all those vague ones, but they can go to serious ones like, seizures, coma, and death. And it's very important that we see this coming. Which of the following, so patients that we've talked about, drinking a lot, which of the following can cause polydipsia? A couple of things we should have in the back of our minds. Polydipsia, if we can go again to the chat box, so I put a couple of options, choose the single best. Very well, very well. Everybody seems to be going for E. Very good. Well, thank you very much. Right. I hope that is the answer I put. Yeah. So causes of polydipsia. So we're talking about people drinking quite, a lot. We've said the threshold is about over 3 liters. These ones are drinking about 7 to 9 liters a day. But there are other people who are also drinking because of other pathologies. Not everybody taking too much water has psychogenic polydipsia. There are other things worth thinking about. And, hypercalcemia, we talked about it. Diabetes, you remember the P's, polyphagia, polyuria, polydipsia. And then there's one that we don't commonly see, but they're in the background as well, is diabetes insipidus. So when, when we are faced with a patient taking lots of water, coming in with symptoms, these are some of the things we want to have at the back of our minds. So we did a BM. I don't know if it was put in the chat box. We made sure that the BMs were okay. Yeah, we could do an HbA1c as well. Which other things? If you did ketones, probably you can explain it is reasonable to make sure that our patient does not have diabetes. We did we checked for the calcium. You can check, PTH and that kind of thing if you wanted. We've done the urine analysis. So diabetes insipidus. So on the next slide, if we have patients' things, how to deal. This is my nice handwriting when I'm not in a rush, when I'm not on call. And I've summarized one of the simplest ways to, manage patients. They are drinking a lot. They are passing lots of water. So patients who are having polyuria, if they are passing polyuria, lots of urine that is dilute, how to manage them. So one of the ways I find the simplest way of thinking about patients with polyuric dilute urine is to measure their serum sodium. If they are passing lots of water that is dilute, and we find that their serum sodium, you find that it is low, less than 135, it means they are having, they are drinking lots of water, they are passing lots of water, which is dilute. They are just likely drinking a lot. It's likely consistent with psychogenic polydipsia or primary polydipsia. On the other extreme, if you check the sodium and it is high, so they are passing lots of water, but actually they are dehydrated, then that is consistent with diabetes insipidus. Just to remind us, in the interest of time, diabetes insipidus is a problem with the ADH, antidiuretic hormone. So failure for the antidiuretic hormone to work on the kidneys so that you can concentrate the urine, so you're passing a lot of it. And that can be due to either problems with the production of the ADH, or which is the chronic diabetes insipidus, or resistance in the kidneys due to several reasons, including hypercalcemia. And if you're in between, so those are the extremes, but sometimes we have an overlap. And I wanted to take a minute here to talk about in there the water deprivation test. Sometimes it is in the middle. It is actually normal, the sodium, but there is something that is happening. One of the things, and especially those of you who have done MRCP or who will be doing it soon, it's important to remember the water deprivation test. Okay, now that is not where I wanted to go. Yeah, just to take a minute, the water deprivation test can be used to work out the differences. These are all patients who are passing lots of water. That is, so we can work out whether it is due to them just drinking, or it is a diabetes insipidus picture, and whether it is cranial or nephrogenic. So I can see have 5 minutes left. We'll take 1 minute to talk about that box to summarize it. So if we start with the serum osmolarity, people who are drinking, they're drinking lots, they're going to have dilute blood. So their serum osmolarity is going to be dilute. Whereas those ones who are failing to concentrate the urine because they are weighing, and they're going to be weighing a lot, they're going to be dehydrated. So if you start with the serum osmolarity for diabetes insipidus, it's going to be higher. Whereas for polydipsia, you can see the first line is going to be less than 295. And then when we look at the urine osmolarity, you remember the ones who are failing to concentrate urine, it's definitely going to be the urine is going to be very dilute. So you can see urine osmolarity for both cranial and nephrogenic is going to be quite low. For if you're drinking a lot, it will be low, but probably not in the range of diabetes insipidus. And then you can give them desmopressin, ADH analog, and you see if the problem is that they couldn't produce it, which is the chronic diabetes, you can see that the urine, they can start concentrating it, and the urine osmolarity improves if you see on cranial diabetes. But if it is resistance, it won't do anything. So management, and I think somebody mentioned this. Well, we are coming to that. So the main problem is drinking too much water. So the main issue is to fluid restrict them. But then if they are having severe symptoms, we probably need to do more than that. And we should be looking at if they're having seizures, they're in coma, they are not dead. We should be losing hypertonic saline infusions, that is 3%, to increase that sodium. As somebody mentioned, salient issues, we need gradual correction as opposed to exponential correction of the sodium. So the target should be 8 to 10 millimoles over 24 hours. So I think somebody has already identified that. Did we go over 13? Hopefully not. So you can see in day 1 to day 2, we moved by 9. On day 18, we moved by 4. So the answer is no, we didn't move. We moved at the gradual rate. So it is important we correct the sodium. We can, if they're having severe symptoms, we can give them hypertonic saline. If it's not, then we just fluid restrict them and make sure the sodium is going up, but not more than 10 millimoles. A few minutes left, but if we can use the chat box, why don't we? What is the problem with the sodium just jumping from 1001 to 132? If we can use the chat box to see why is that a problem? Is there any problem with that? As somebody has rightly identified? Yes, CPM. Very good. CPM. So demyelination syndrome. Very good. Right. So management in a wider perspective, we are going to be enforcing things that can help with fluid restriction through patient education. It's going to be difficult because of psychosis, so CBT, behavior theory involving the family. Medications might be used. They're not very good. You might need the family to get involved. You might need the RENOP team to get involved. We might need the physicians. MDT approach has a very crucial role. So in summary, we've reviewed a case of confusion in the context of hyponatremia. We've looked at the management and the outcome, and we've also reviewed the differentials that are likely in that context, as well as the salient issues when managing cases of this nature.